So the title of the lecture today is Acquired Macular Diseases. And what we will be discussing today is, of course, not everything. Thank you. Is a central serous retinopathy, vitreoretinal interface abnormalities, juxtafoveal telangiectasia, photic maculopathies, and if we have time, macular edema. What I will not be discussing today is AID and coronary vascularization because you're going to have a lecture for an hour on this hopefully next week. Traumatic maculopathies, inflammatory conditions and tumors, and all kinds of dystrophies that affect the macula and beyond will not be discussed today because I know that you have a lecture on that elsewhere. So let's start with central serous retinopathy. Now, by definition, it's an idiopathic, until now considered idiopathic neurosensory retinal detachment. We will realize very soon that it's not always a neurosensory retinal detachment. CSCR is actually a spectrum of diseases and of pathologies that affect the retina that is related to the choroidal permeability and is related to the venous circulation in the choroid. So, but that's how it was defined, and that's how we define it up to now, until more information about the pathogenesis is understood. It usually affects healthy individuals. I know that most of you know that it affects mostly males. 90% of cases are in males, and generally in people between the age of 20 and 50. If you have somebody with CSCR that is above the age of 50, then you have to start questioning, is there something else? Is there an occult choroidal neovascularization? Is there a choroidal neovascularization? Something else that is unusual for people to have CSCR beyond the age of 50. And it usually happens in people who are emetrope or hyperope. It's extremely rare to have myopes who have thin choroid develop central serous retinopathy because usually CSCR is associated with thicker choroid. And it's uncommon in Black people. The pathogenesis, we realize that it is a choroidal hyperpermeability that is very clearly visible on in endoscopic green angiography. You have an altered retinal epithelial barrier. You know that is the outer retinal barrier from the anatomic directions that we're giving you. And you may also have a difficulty of the RPE pumping fluid from under the retina. So there is a functional abnormality in the RPE. And you can have sometimes a central serous retinopathy that is associated, that is not idiopathic, but associated with other conditions such as pregnancy or end-stage renal disease, where there's a lot of overflow of fluid in the body. And sometimes in organ transplanted patients who receive a lot of steroids, and in general, corticosteroids, even inhalers, can declench a central serous response. So what are the signs of central serous retinopathy? Well, first of all, and the one that you guys mostly know, is the neurosensory retinal detachment. And this is, you will see that you have around bleb, an elevation of the retina that is well delineated, well circumscribed. It usually has transparent fluid. And if you do an LCT, you may have a little bit of, what we call like elongated photoreceptor outer segments. For instance, if you see that here, this is not a very thin layer. This is a layer where the photoreceptor outer segments are elongated because all those discs that are being shed are not being phagocytosed readily by the RPE. So you can have that, and this will translate sometimes in a little bit of hyper of some whitish dots that you see behind the retina. And the neurosensory retinal detachment is due to a leakage at the, from the RPE, a dysfunctional pump. And how you see that, there are two types of leakage that you can see. The classic one is the spoke stack, but most of the leakage points are actually stuck as a little point. And then this point, during the fluorescein angiogram, increases in size and it becomes a little bit fuzzy, and then it fuzzes even more until you get, a bleb of pooling of fluid. This is what we call the ink blot pattern. The classic one that is described in books and that we see sometimes, and I'll show you a picture later on, starts out with a little bit of a tiny spot that you see early on in the angiogram, and that this spot tends to, increase in fluorescence and it, come out like an umbrella, and then it comes down like a spoke stack. And here is the late pooling of the neurosensory retinal detachment. So the neurosensory retinal detachment is here, okay, but the origin of this fluid comes from here, and this is why you need to have nice angiograms that show the early frames so that you can see the spot that is leaking. So here's an example of a central leak, because you can have also neurosensory retinal detachments due to leakage outside the macula. So central leakage is, for instance, like this. where you have the neurosensory retinal detachment right there. You have the photoreceptors that have elongated outer segments. And you have the hotspot here. This is what causes this, and it ends up being a smokestack pattern at the end of the angiogram. You realize that this is a relatively early angiogram because the vessels are very sharp and very bright, but you know, even without a timer, that this is a late angiogram because the background fluorescence is quite dim, and even the fluorescence in the vessels is quite dim. If you do an OCT and the line goes, down here, this corresponds to the line that we're seeing right there. Okay, so you've got a nasal, the nasal part is here. The thickened nerve fiber layer. You know that the line passing through this area gives you this shape of where the retina is elevated, and then you've got serous fluid under the retina, and the RPE layer is intact anatomically. Okay, if you do autofluorescence, you may see in the bleb of the neurosensory retinal detachment a little bit of hyper-autofluorescence. This is because all those fluorophores that are coming out from the discs are, stagnating into the neurosensory retinal bleb, and the RPEs are unable to take care of it. Here's another example of a neurosensory retinal detachment through the central leak. You can see the central pinpoint hyperfluorescence that increases, and then here it is, it's increasing really a lot, and you get pooling, and here is the neurosensory retinal detachment edge that you can see with pooling. Now, as I said earlier, you can have an extramacular leak. Here's a patient who has CSCR, but the leakage point is above the macula, okay, and it tracks down. You can see the RPE changes from the chronic egress of fluid and the influx of fluid into this area. And then here, this is a vertical OCT, and on this vertical OCT, you can see that the superior part of the macula here has, is it superior? No, it's actually the inferior part of the macula has all this fluid right there, okay? So, you can also have just pigmented field detachment. We've seen a case like this morning in the clinic. Sometimes the CSCR spectrum is only pigmented field detachments. And how you detect them is clinically, the pigmented field detachments look like little, blebs that are usually orange in color. And on a fluorescein angiogram, the pigmented field detachment tends to hyperfluoresce early, and then it stays demarcated, well demarcated, and just increasing in fluorescence without increasing in size and without being blurry. If you do an OCT, the OCT shows the elevation of the pigment epithelium, okay, of course, the elevation of the retina on top of it, but everything here is serous and hyporeflective because it's clear fluid. And here, this is another pattern that you can see in CSCR, where you have both the pigmented field detachment and the neurosensory retinal detachment, called type 3. So yeah, here is I'm showing you here how a PED would look on a fluorescein angiogram. You have very early on, an area of hyperfluorescence. You know that this is an early time because you're seeing the laminar venous flow, so you know that you're in the arteriovenous phase. This is early. As you come into the early recirculation phase, you see that this hyperfluorescence has exactly the same shape and much later, where the fluorescein is dying and going away from the eye and everything is dimming. This area is actually picking up the fluorescein even more because with every heart pump, there is more and more fluorescein going into this very localized pigmented field detachment, which does not have the capability to extend because there are very good, tight junctions between the RPE and the poricapillaris via the Brooks membrane. This you know from the anatomy. What are other signs of central serous chorioretinopathy? Well, you have subretinal precipitate. You can have subretinal fibrin, this yellowish, fluid. You can have just RPE changes, as you can see in the bottom picture there. Those changes can come in under the fovea, and they will disturb the vision. The reason is because fluid actually goes backwards, and if the patient sleeps on his or her back, then the fluid tends to accumulate at the fovea, and you can get these RPE changes. And if you have chronic leakage, you get what we call epithelial tract, which you can see clinically, as RPE changes, tracts of RPE changes, but on a fluorescein angiogram, or even on an autofluorescence, you will see an area of hyper autofluorescence that goes down, like a waterfall. Here's another case where there is an acute leak in one eye. This is the same patient. There's an acute leak in one eye right there, but the other eye has also signs of RPE changes, and this is usually like a telltale sign that tells you that this patient has had episodes of CSCR, even if the patient is asymptomatic. So you usually tend to see RPE changes in patients with CSCR, even if they're asymptomatic. Now, and sometimes the leakage is so bad that you can have an exudative retinal detachment. Okay, so I just want to tell you that one of the things that you have to think of when you have an exudative retinal detachment is not just inflammation. It could be usual effusion, but sometimes it could also be central serous chorioretinopathy when the choroid is quite thick. So it has to be in the differential. How do people with central serous present to you? Well, generally they have like a new onset of changes in their central vision. They can have micropsia, meaning that they start to see things being smaller. They can have metamorphopsia, but things look a little crooked. They can have a central scotoma and an increase in hyperopia because the eye becomes the distance between the fovea and the cornea gets smaller. So they need hyperopic corrections, and this is what I think that you can do for them to help people. I have CSCR is if you are not going to treat them immediately, then the least you can do is maybe prescribe new glasses that can help. I'm making a lot of noise. I don't know where it's coming from, but I apologize if it's bothering you. So, yeah. How do you diagnose central serous? It is, of course, when you look at the eye, but with biomicroscopy, you're going to see the elevation, or sometimes the PEDs. But OCT is really, really very important and crucial. You can do autofluorescence and fluorescein angiography. You're going to see that in a moment. So, the best way to diagnose central serous right now is by doing an OCT, which is non-invasive and extremely useful. It will show you, it will detect very clearly for you the area, the edge, the limits of the neurosensory retinal detachment and any PEDs. And it will tell you if it's an acute or a chronic neurosensory retinal detachment, because if it's chronic, you will see these, elevated and elongated photoreceptor outer segment. And it will, if you do an OCT with enhanced depth imaging, you can actually image the choroid. And in most cases, people have actually thickened choroid. Now, the choroid should be approximately the same thickness of the retina. And if it's more, then you have to start thinking that this patient has thick choroid. Okay, sorry about that. Okay, now autofluorescence is also it's non-invasive, and you would tend to see hyper. Oops, I'm so sorry. I'm not used to this. There we go. So you will see a bleb, or a round circular area where the bleb is. It has hyper autofluorescence because of the fluorophores that are accumulating in the fluid. Okay, and if you look very carefully, sometimes you're lucky to see the pinpoint hypofluorescence, which corresponds to the pinpoint leakage seen on the fluorescein angiogram. But we don't always manage to see this. And if you have a very chronic central serous chorioretinopathy, what you would end up seeing is the fluorophore accumulates. It's not like fission, but it's the AE. It's material that comes from the disc, that is originally A to E, it's called, and it will accumulate in the blood and will give you this yellowish pigment that may look like this disease. The fluorescein angiogram will just confirm the diagnosis for you. It will show you the hot spot, as I showed you here, as I showed you right there. And sometimes it will show you just the PEDs, and then sometimes it will just show you the sequela of chronic central serous, which is the track and the RPE changes. And the indocyanine really we don't use very much, but it will show you hyperpermeability, so there's diffuse leakage of the dye, and it's mostly useful if you want to, distinguish central serous from PEDs that are associated with polypoidal vasculopathy or AMD, but we don't use it much actually. Okay, so what is the course of CSCR? Generally self-limited, meaning that most people, in 95% of the cases, the fluid is going to disappear with time. However, the fact that the fluid disappears does not mean that the vision returns perfectly as it was. Often people will complain of still like changes in color visions, difficulty with stereopsis, and sometimes even night vision problems. So you may want to discuss that with your patient, that although the fluid is gone, the vision is not perfect. Recurrences are common, okay? So you have to also, discuss that with patients. And of course, when central serous drags for a long time, you can have visual decline. that are due to, the RPE changes, the retinal pigmented scars. You can also get, subretinal fibrosis and these atrophic tracts, that cause a lot of changes when they pass through the fovea. Okay, you can also, when you have a chronic CME and the RPE is having a chronic central serous detachment, and the RPE is having a hard time pumping all that fluid out, at one point the RPE just becomes very dysfunctional. And so the fluid can come also in the retina and be associated with the CME. Choroidal neovascularization can happen. It is not very common, but it can happen, particularly if you do laser. For those patients, sometimes the area where you do laser is an origin for future development of CNV. So you have to be careful if you contemplate doing laser. Okay, and of course, if you have complications and retinal pigmented sequela, that is going to compromise vision. The differential diagnosis, I want you to all take your cameras, please, and I know that you love cameras, so go ahead and take a moment to picture this. This is the differential diagnosis of any serous detachment. You have to consider, when you see fluid under the retina, you have to consider inflammatory conditions of the retina and the choroid, malignant hypertension, okay, AMD, of course, because you can have fluid under the retina. Vitelliform macular dystrophies, particularly in chronic CSCRs, that look a little yellow. Tumors as well, because they can exude fluid. Optic nerve pit maculopathy. If you're not very careful, you may see fluid, and you have to examine the optic nerve, and sometimes the pit is not very obvious. Retinoschisis and segmental retinitis pigmentosa. Why? Because sometimes, as I showed you, the CSCR is so chronic that it causes RPE changes in one sector inferiorly. And you look at it, if you have all these RPE changes, you say, oh my God, this is RPE. Well, actually, it could be central serous. Okay? So, how do you treat central serous retinopathy? Well, usually, you treat it if the fluid persists. So, if it's a first attack, first time the patient has it, you may want to wait 1 or 2 months, especially if there are no occupational needs that, and that mandate that you treat the patients. Okay? But if you have a patient that has occupational needs, or is a one-eyed patient, you may want to consider going in earlier. You may want to treat if the patient has had a bad outcome in CSCR in one eye and now is having a fresh CSCR in the new eye, and then that chances are that there probably will be some bad outcome in the new eye, so might as well treat early. And chronic cases, you should treat them actually. How do you treat them? Well, there are 2 ways of treatment. Right now that are approved. Okay, the first is the focal laser foot coagulation, and that basically you apply a green or yellow laser to the point of leakage that you determine using the fluorescein angiogram. It should be a very, very light gray treatment that is focused on the lesion itself. It has to be light, and it has to be safely away from the center, because you don't want to treat and cause a complication or treat close, and then with time that laser scars enlarge, and if it enlarges after a few years, it may encroach on the fovea, and you would not have done the patient a favor. So you have to kind of determine what is a safe place to treat. It has to be outside the foveal avascular zone edges, and preferably above 1,000 microns from the foveal avascular zone edges. The complications can be accidental foveal burns, and as I said earlier, choroidal neovascularization that may erupt from the spot of the laser, and the scar enlargement. So these are all complications that you have to think of and discuss with the patient. Photodynamic therapy is the treatment of choice if you have a central leak that is close to the fovea. It will hasten the resorption, and it tends to decrease cause choroidal atrophy, so it tends to decrease the choroidal thickness and possibly therefore decrease the chances of recurrence in that area. Okay, and you can use either a full dose of Visidyne. Photodynamic therapy uses a dye that's called Visidyne, a product that's given intravenously. The product goes throughout the body, and after 10 minutes of infusion, you wait. The infusion takes 10 minutes, and after 5 minutes after the end of the infusion, the patient is placed at a specific slit lamp with a specific laser beam that is focused on the area that is leaking for about 83 seconds. So you can either give a full dose of the product and put the laser beam for half the time instead of 83 seconds. You can do it 41 seconds or 42 seconds, or you can give half the dose of the product and give the full 83 seconds of laser shining into the eye. So either way works. I like half dose better, but that's up to question. You can have as a complication choroidal atrophy because the PDT tends to create closure of the choroid capillaries, so there may be atrophy, and there may be some decreased vision if it hits the fovea. So you try as much as possible not to hit the central fovea. You definitely try very much not to hit the optic nerve there. Okay. Now medical treatment don't work very well. We used to use sometimes eplerenone, which is it's an aldosterone inhibitor, but the studies shown that they don't work any better than placebo. So forget it because they just give you side effects. And Diamox in general does not work very well. And a lot of people, especially in the private, tend to give injections. Anti-VEGF that has not been proven to work in the central series because the mechanism is not a VEGF-induced mechanism. It has something that has to do with permeability of the choroid and the venous structures. So that would not work unless some cases of central serous choroidal retinopathy have underlying abnormal vessels, occult nerve vessels under them that may be contributing to some leakage, and in this case, you may want to try one anti-VEGF injection. Okay, but it's very important that you do counseling and refraction for these patients. It really is important, and you have to tell them not to use steroids. Okay, any question about central serous now? Yes, I hear you. Go ahead. No. I'm sorry, I interrupted you. I thought you finished your question. Go ahead. Yeah, okay. No, we don't need to do an FA if you know what the diagnosis is. It looks like CSCR, if it walks like a duck, if it quacks like a duck, it is a duck, right? So if you have a patient who's, young enough, male, pretty stressed, you have a neurosensory retinal detachment, you do an OCT, and you have a neurosensory retinal detachment. You look at the retina, and all what you see are a few RPE changes. You may do an enhanced depth imaging OCT, which is not invasive, and you find out that the choroid is quite thick, okay, and everything fits. So at this point, it has been just for a month or a few weeks. You may want to try to say, okay, I will not treat you now, but I will bring the patient back in a month and do another OCT and see if it goes down on its own. A lot of times it just the fluid just decreases. So you don't need to do an FA. But if you contemplate treatment, you need an FA because you need to know where is the point of leakage, right? Yeah, so that's when you do it. Yeah. Good question. Yeah. Go ahead. One part at a time because I'm old and I don't remember things. Yeah, go ahead. High risk PED. Well, in CSCR, the PED is serous. The elevation of the where is it? The elevation is clear. Okay, you have an elevated pigment epithelium, but you don't have anything under. You see the Brooks membrane, and you don't have any blood there, and you don't have anything hyperreflective that would suggest that you have a choroidal neovascular membrane coming up. There was one I showed you earlier. Yeah. Okay. So this is very clear. You've got the Brooks membrane, you've got the elevated RPE, you've got the neurosensory retina. The ellipsoid zone is basically covering this, and you don't have any blood. If you have blood, it will be hyperreflective. If you have the choroidal neovascularization, you will see structures. You're going to see that next week. You will see structures here, and you hyperreflectivity here, and it's never so regular. Okay, next question. Shadowing? What shadowing? If there's shadowing on the realize here that you don't have a lot of shadowing here because it is hyperreflective. If you have macular here, you will have more shadowing because the light is not going to pass through very easily. But I don't know if I answered your question, nor do I know if I understood your question. No, because you don't know where the shadowing is coming from. If everything here is very, very clear and you don't have anything here that contributes to the shadowing, and you only have a pigment epithelial detachment that has hyperreflectivity under it, then you will have shadow. And in this case, you will use either fluorescein angiogram, or you can use an OCTA to decide whether these are vessels, whether this is just fibrin, and so on. But usually you don't see that in central serous. A pigmented field detachment that is due to central serous is usually hyporeflective. There's no reason for this to have blood, or to have fibrosis, or to have vessels. If there are, then this is not a central serous. Then you're dealing with choroidal neovascularization. Yes. CNVM, the classic one in choroidal neovascularization, will not show you leakage, will show you a hot spot. And if it's an occult membrane, it will show you like a plaque. Okay? But in the central serous, what you would see, and if you had polypoidal, you will see things that look like a grape, grapes on a stem, they with polyps and lines. These are the branching retinal vessels, the branching retinal network, and each branch finishes with a little bit of specular dilation that are polyps. Okay, so they will look like polyps. But on a where was it? I had an ICG. But if you have a central serous or retinopathy, you will see a diffuse hyperpermeability. Okay, and then you see the pigmented field detachments will look like this. Okay, yeah. So they look different. While in CNV, this will not be like this. It will be like a hot spot, or it will be a plaque. It will be an area of hyperfluorescence. Okay. All right. Now, the second thing that I'm talking about today is the vitreoretinal interface abnormalities. Which means either vitreomacular traction syndrome, retinal membranes, epimacular membranes, and macular holes. What are the stages of PVD? I think we've discussed that in the anatomy lecture. Everybody has vitreous in their eyes. The vitreous is attached to different places in the retina, and the strongest adhesion of the vitreous to the retina is where? Huh? Yes, vitreous base. And the vitreous base is situated where? At the aura serrata. Excellent. Okay, so you guys remember that. I am so happy. The vitreous base should be around here. So the vitreous is always going to be very, very severely attached here. And the second strongest adhesion is at the optic disc. Exactly. And then the third is at the fovea. Okay, at the fovea, and then the rest is at the vessels, and then the least adhesive is all around the retina. So with time, as we grow older and the vitreous becomes very liquefied, some of the fluid in the vitreous is going to go behind the cortex of the vitreous, and the fluid is going to start to accumulate between the retina and the papilla and the posterior cortex, and the fluid is going to start to push the vitreous anteriorly. Okay, so stage one is when you have you don't have any vitreous that is detached from the optic nerve, and you have the vitreous that has detached from around the fovea, but the fovea is still on. Okay, the attachment is still adherent. The second stage is when this goes off. Okay, the vitreous is detached from the fovea, but is still attached at the optic nerve. And then later on, what happens is that this one kind of slips off, and it goes. This is you have more and more fluid, so it detaches from everywhere else, but you still have attachment at the optic nerve. That's longer, and then later on, the whole thing, even at the optic nerve, detaches. You make it the white string, and the vitreous gel is kind of in the front of the eye, and here is just the clear fluid. So this is the normal aging process. Now, this PVD may be complicated by a persistent adhesion of the vitreous to the fovea. Okay. And sometimes, not just by adhesion, but actually by pulling of the vitreous cortex on top of the fovea, causing vitreomacular traction. So you have vitreomacular adhesion and vitreomacular traction. Here's an example of vitreomacular adhesion. you have basically a perifoveal posterior vitreous detachment, okay, which is the cortex. It's detached from the retina, but it's still attached to the fovea. But there's no distortion of the macular anatomy, and there's the patient doesn't feel it. It's asymptomatic, and therefore it is not pathologic. It's part of aging, and you just have to watch that you don't do anything to that. But sometimes this adhesion can become strong, and where the vitreous doesn't want to let go of the retina, so it pulls the retina with it, and that's when we get traction, and that's when we start to have complications. So here you have vitreomacular traction, okay, and which is going to create some structural disturbances. It may create macular edema. It may create some rips. It may create some cleft at the fovea, and even dehiscence of the foveal roof, causing macular holes. So, and in this case, in all these cases, in general, the patient starts to experience metamorphosis. So, what happens when you have vitreomacular adhesion? In the beginning, you may wait for spontaneous separation, and it can happen. Okay, and in this case, the separation just patient suddenly sees better on his or her own. But of course, if the vision is decreasing, if you do an OCT, you find that there's traction, you give it the time. Next time visit, 1 or 2 months or 3 months later, you find that it's increasing. The patient is starting to really complain about vision. Then you may want to consider a vitrectomy to release this traction and flatten the retina back. Okay. In general, when the vitreomacular traction is more than 50%, that's adhesion around the fovea. That's a good case to do vitrectomy. Okay, so I'm not going to talk about the Jeffia archiplasma. At one point in time, we used to use we didn't use to use it, but we had the opportunity to use this pharmacological vitreolysis. This is plasmin that was injected into the vitreous, and that causes degeneration of the adhesion between the cortex and the fovea, but it caused a lot of problems. And I would say that I think most of the retinal community in the world does not use this anymore, and it would only be successful for very, very limited endpoint vitreomacular tractions that where vitrectomy would be too risky for the person. Vitrectomy is a much better controlled way than to relieve the traction. The second thing that can happen from the adhesion of the vitreous to the retina is creation of epiretinal membranes. In the macula, they will be called epimacular membranes. Okay, and they are due to proliferation from the Muller cells, and from sometimes the retinal pigment epithelium in certain pathological conditions. So it really is a tissue repair response, just like PVR. It's a mini PVR, mini proliferative vitreoretinopathy. Okay, creation of epiretinal membranes because there was inflammation in the eye, or because there was trauma to certain places, or because there were some, rents in the, retinal structures that create this ability to proliferate from the Muller cells and to expand and to grow sheets on top of the macula. So usually, retinal membranes are asymptomatic, are idiopathic, and they can be, of course, asymptomatic, but in most cases they do create some metamorphoses. They can be a consequence of retinal detachment. They can be a consequence of laser in the eye, because it creates inflammation. They can be a consequence of retinal vein occlusions. CRVOs are known to create, to give the eye epimacular membranes. Proliferative diabetic retinopathy, not just epiretinal membranes, but actually full fibrovascular proliferations can grow on the surface of the retina, and trauma. So all these are causes of epimacular membranes. What are the symptoms? Well, it depends on how much the membrane is pulling on the retina and how much distortion is it creating, and is it by the creation of distortion is creating any also intraretinal edema. Okay, so you can have diplopia, you can have metamorphosia, micropsia. If you do a red-free picture of the retina, you will see the limits of the epimacular membrane really, really clearly. Okay, and if you do a fluorescein, what you're going to see is the consequence of the pulling, which is the distortion of the vessels, but oftentimes leakage. Okay, because when you pull on the retinal vessels, they tend to leak. Okay, but an OCT is generally what we use to show the epiretinal membrane. And so what it would show is a hyperreflective membrane, that grows on the surface of the retina and that causes, surface irregularity. Here, for instance, you've got a vitreomacular traction. This is the cortex. It's not epiretinal membrane, but it's attached to an epiretinal membrane that's pulling on the retina. You can see how much stretch is there of the retinal tissues. In general, epimacular membranes don't tend to just disappear. They will tend to contract until the healing process is over. Now, the healing process is over before the patient becomes very symptomatic. We can leave the patient at peace. But if there are symptoms, decreased vision, metamorphopsia, micropsia, increased tortuosity, then you know that you have to interfere. Okay, it is very rare for an epiretinal membrane to just lift off. That would not really happen. So, how do we treat epiretinal membrane? Surgery by doing an plasmagnectomy and epimacular membrane peel. And of course, the indication will depend on the symptoms and the extent of the visual loss and the duration of the visual loss and the visual needs of the patient. In general, the outcomes are not too bad. Of course, there are always complications with retinal surgery. You can have retinal breaks, you can get hemorrhages, you can get a retinal detachment, infection of the eye, and endophthalmitis. That would be a disaster. Some epiretinal membranes occur, and with every vitrectomy, you know that there is a risk of cataract. In 50% of cases, in 2 years, patients will develop nuclear sclerosis. That has to be taken into mind. Full thickness macular hole is the third complication of the vitreomacular interface, pathology. What are macular holes? These are full thickness holes, of the full thickness adhesives, the loss of tissue of the retina, the entire retina. Usually they're idiopathic. Okay, they come with age. They affect mostly women, and mostly women above the age of 60. Now, initially, Dr. Donald Das, rest in peace, has described what he thought was the mechanism of developing a hole, and he attributed holes to tangential traction. That means you have basically the fovea. The fovea is concave and dips, and then if you have a tangential traction, if the vitreous starts to pull on the retina sideways, okay, then that dip here, that depression is going to elevate, okay, because you're pulling sideways, so it's going to elevate, and then there will be dehiscence, okay. So that was Dr. Das's mechanism. Now we know that this, of course, happens, but we can also get macular holes when the vitreous pulls from antero, from postero-anteriorly. Okay, this way. So just to familiarize you with the grades of the macular hole or the stages, Dr. Das described this being as the normal fovea. Okay, and then the first sign of a macular hole, which is not a thickness hole yet, it's called an impending macular hole. Is when the vitreous pulls on the side this way, and then the fovea becomes elevated. So you have clinically, if you're a very good clinician, you may see a yellow spot, and that is all that xanthophyll, pigment that's in the fovea is going to come centrally. Okay, and then as the traction of the vitreous increases on all sides, this spot is going to become a ring. Okay, it's a spot, it's going to be large, and it's going to become a ring. That is still the stage 1B, which is called an impending macular hole. And then when the traction is too much, okay, you start to have a hole in the center, and that's what we call a stage 1B, a hole, and it's difficult to see. You cannot see this clinically, okay, but this is adhesive in the center here, okay, but it's under the prefoveal cortex, so you can't really see it because the vitreous cortex hides it, okay. Now, this can abort if the vitreous detaches. Nothing happens, things go back in place, everything is okay. But if it doesn't abort, if the traction continues, then you can either have the vitreous that pulls off, here and creates a thickness hole, stage hole, which is a tiny hole but full thickness hole. Stage 2, 3, and 4 are full thickness holes, okay? So it can create either a tiny hole by the vitreous being pulling this way, or it can rip, the cortex can rip, and then it rips and it will open up as a can opener, okay, like when you open a can and you have a little operculum right here, and you have also a stage hole. So a stage hole can happen either by this action or by a can opener technique in the cortex, and then this will enlarge, become a stage 3 macular hole. Now, the difference between stage 3 and stage 4 is that stage 3, you have an operculum, the vitreous is still attached to the back surface of the retina, and in stage 4, the vitreous has completely pulled off the fovea, the macula, and even the optic nerve. You have complete PVD, and that's the stage 4. Okay, so these holes, of course, you can see them. Stage 2 holes, if you're good, you can see them. It's about less than 400 microns. Now, the way we understand macular holes nowadays is actually by the use of OCT. We've seen that you can get also, as I explained to you before, you can get anteroposterior traction. And here's this is one of the first articles that came out that showed the development of macular holes. It was fascinating at the time. Here's the cortex, okay, that's being pulling on the retina. You have this inner lamellar holes. More pull, more pull, more pull, and then at one point this snaps. Okay, this breaks, and here as it snaps, you can you can get adhesions in the outer retina, and now you have what we call an outer hole, right? You have a hole here, and you have kind of a hole here, but it's not thickness because you have something that that connects it here. So you have an outer hole, and this as it pulls even further, at this point, you can have a break, okay, in the inner retina that now connects to the outer hole that is enlarging slowly, and now you have a thickness hole. So these are all mechanisms that you should be aware of. And here's I'm just explaining this, again, same thing. Okay, so let's proof. Okay, so the operculum itself, okay, it appears as you don't always have an operculum, but if you have an operculum, it's mostly made of glial cells, pillar cells, and some cones which are present that were present in the fluid. What are the symptoms of macular holes? Well, a lot of times it's an incidental discovery, during an ophthalmology or incidental discovery where a patient is, examining both eyes and finds out that he or she doesn't see so well. Okay, it's not sudden, like central serous, you have a sudden decrease in vision. Macular holes, it takes time. People may not realize it. Sometimes people have, they complain of abrasions in the center or a scotoma. And in general, the vision decreases and it kind of stabilizes. It doesn't continue to decrease. Okay, the fundus exam will definitely show you the hole itself, often with little white spots in the bed of the hole that correspond to, that possibly macrophages and RPE cells that are trying to, eat the fluid that is generated there. You do have often a cup of subretinal fluid around the hole because, as I said, the vitreous basically pulls on the retina, so the retina everts, and you have all that fluid that is no longer in contact with the RPE. The RPE has, hard time sucking that out. You can have an associated epiretinal membrane with it here. On an OCT, this is the gold standard. This is how we diagnose when we have a full thickness adhesions of the retina, and with cystoid changes, edema on both sides. Here's one where there's an operculum. Oftentimes you see inverse shadowing because the light goes right through it, so you have increased inverse shadowing here, and sometimes you actually see the vitreoretinal adhesion. Okay, so when you do an OCT, you can actually determine specifically if you do an OCT centered on the center of fixation, and you do not just the raster cut, but you try to do a radial cut. So the center of fixation, the radial cuts of the OCT will all be centered on the macula, on the center of the macula, and then you'll have radial cuts that go around the clock to see whether there's any closure, of the inner walls. In this case, this will no longer be a full thickness hole. But if you have at any one place, full thickness adhesions, you know that you're dealing with a macular hole. And sometimes macular holes are not visible just online, so you have to read the whole OCT scan. Okay, So this will tell you if it's a full thickness hole or whether it's an inner or lamellar hole or an outer hole. Now, the lamellar hole and inner lamellar hole is formed by the same process as a full thickness hole, but in general, the photoreceptors remain intact. In general, you don't have subretinal fluid. Okay, you do have fluid in the retina, stick-like changes, but no fluid here, and there's no window effect. And these can be left and observed. They rarely evolve. Outer retinal holes, like we saw here, they can happen after high laser intensity injury, photic injury, or even up to retinopathy, or telangiectasia. Okay, you would have intact inner tissue but loss of the retinal tissue outside on the out. Pseudo-macular holes are different. If you look, this is a pseudo-macular hole. This is not an inner lamellar hole. You see the retinal structures are intact, all the layers are intact, and all what you see is an epiretinal membrane that is kind of pulling the retina, the fovea towards each other. So it gives you an increased depression okay, but it's a lamellar hole. There is no loss of tissue. All the layers are clear and intact on both sides and on every side of the hole, okay? So pseudo-macular holes can sometimes, people can think that somebody has a pseudo-macular hole clinically when they have, for instance, RPE apathy, like this case, for instance, this is an RPE apathy, and people can think that this is a hole. Actually, it's not once you do an OCT, or in cases of just, macular telangiectasia type 2, for instance, you may have pseudo-macular holes there. So this is exactly what I say. So how we're gonna close, and I guess I'm gonna give you the rest of the lecture some other time. The current treatment for macular hole stage 1, the impending macular hole, you don't do anything because more often than not they will actually resolve by themselves. But stage 2 macular holes need to be operated. Okay, it is very, very rare for a stage 2 hole to close. So a very tiny stage 2 hole needs to be operated, and that what we do is a plasmapherectomy with peeling of the hyaloid, and then in many cases peeling of the internal limiting membrane of the glial cells. And we put gas, ask the patient to look down for a while, and that should close it in most of the time. The success rate is quite high, especially in experienced hands. You can have unsuccessful outcomes with, increased, with the recurrence of the macular hole or the loss of the macular hole. Most of the time, these will tend to need more interventions. Complications you need to know, and with every detectability, there is a risk of cataract, there is a risk of IOP. There's nucleus sclerosis is very common in the years that come, come right after surgery. And the 2 years, the chances that patients will need cataract surgery. One of the things that can happen is also ulnar neuropathy. Okay, people are asked to have their face, prone like this, so that the gas pushes on the retina to close the hole, and by putting their, pressure on their elbows, they can get an ulnar neuropathy. So you need to warn people, and there's of course the late reopening of the hole. And as with any surgery, there's always a risk of endophthalmitis. So I will stop here. I do have a lecture next week about further neovascularization, and if we have time, we'll go over the juxtafocal so that we can give time now to our distinguished speaker. Thank you very much.